It's time for The Verdict. The Verdict is a lively discussion of current events and legal issues pertinent to Oklahomans. The Verdict is hosted by Kent Myers and Mick Cornett. It's time for The Verdict.
And welcome once again to The Verdict. I'm Mick Cornett. My co-host is Kent Myers. Kent is one of Oklahoma's top legal experts, and today we're not talking about legal issues. We're going inside people's mouths.
Inside people's mouths. That's not you or me, but everybody else, I guess. So often we do shows that may appeal to somewhat limited segment of our audience, but today is not the case. Every one of you that is watching today will be interested and will have a need to know some of the information we're going to give you, because every person, of course, regardless of the state of their dental health, is going to know about some of the things that Dr. Paul Shadid, a reconstructive and cosmetic as well as general dentist practitioner, is going to tell us. He's one of the really renowned experts in this part of the country on what we're going to be talking about today, and it will affect each and every one of our viewers.
Assuming you have teeth, you need to watch.
Even if you don't, you need to watch, as we'll show.
Maybe especially if you don't.
Yeah, especially if you don't.
It's The Verdict. We'll be right back. Welcome back to The Verdict. Mick Cornett with Kent Myers, and Kent's going to introduce our guest.
We are really pleased today to have Dr. Paul Shadid joining us. Paul is a longtime friend. He is a native Oklahoma Cityan, graduated from John Marshall High School, did his undergraduate and dentistry work at the University of Oklahoma. After that, he entered private practice and has been in private practice for the last 20 years. He has taken some time off, or in addition to his practice, he has engaged in some teaching activities. And as I indicated in the opening segment, he is generally recognized, although he won't admit it, as one of the leading dentists in this community and in this state, and particularly when it comes to putting back together teeth or jaw defects that have occurred by way of accident or birth or whatever it may be. But we're really pleased to have Paul join us. He has occupied several positions in the Dental Association, both county, state, and American Dental Association. He is married to Jennifer, and he has sons, or a daughter, Jessica, son Paul, and a son Peter, all going to school here in Oklahoma City. Paul, we're really pleased you join us. Thanks.
Kent, thank you for having me. Mr. Mayor, thank you very much. Thank you, sir.
Dr. Shadid, trace your professional history. How did you get to where you are today?
Well, I began undergraduate in 1976 and had some mentors in the field of dentistry that kind of led me down that path. Knew I wanted to go into healthcare, knew I wanted to do something with my hands to try and be a surgeon of some type. Had some relatives that were in the medical profession and saw how many hours and days that they were away from their families, and dentistry was a good path for me. Attended OU, started dental school in 1980, graduated in 1984 from University of Oklahoma, and started private practice along with some part-time teaching at that time. I was a clinical instructor in the Department of Fixed Prosthodontics, which in layman's terms is crowns and bridges, being able to restore people's teeth. Probably one of the main things that led me down my career path as far as deciding to go into restorative dentistry. And soon after graduation, the aesthetic boom and reconstruction boom of implants and cosmetic treatment was beginning. We really never thought that we could do some of the things we're doing today with bonded restorations, porcelain veneers, implants. And I was very fortunate early in my career to have several cases that were involving things like that. It gave me the impetus, the need to continue education. And I did a mini residency in some early implant dentistry. I started my first implant cases in about 1986, 1987, so very early on in my career. And same thing with porcelain restorations, bonding porcelain to teeth. Both of those things were thought of as almost impossible in the early 80s. And I recall an older practitioner at the time, we told him we were going to bond porcelain restorations to natural enamel. He said, why do you want to do that when you can go ahead and just cut the whole tooth down and put a cap on top of it? And little did we know where we are today. And implants have kind of been the same way. Implants, when I was in dental school, were almost looked upon as a renegade part of the profession. There were some really leading pioneers all over the country that were placing stainless steel type of implants in people's jaws. Some worked, some didn't. We didn't know the basic physiology of, or what the human reaction of the bone was to implants, so we had a lot of failures. Implants were looked upon as, wow, you're going to put something in there that you're going to be taking out in 10 years anyway, why are you going to do that? And very quickly in the early 1980s, a gentleman from Sweden started dental research on titanium type of implants that were actually placed in the jawbone. We learned a lot about the physiology of why the bone accepts and why the bone dies, and we took it from there, and I started implant cases in 1987.
Let me change the subject just a minute, and then we'll get back to that.
Sure.
We've had a number of people on the show in the various fields in the medical professions, and we've asked how Oklahomans as a population grade on health issues, mental health, physical health, other areas. Let me ask you kind of the same question about how do Oklahomans measure up to our neighbors and to citizens in other states on their dental health?
To our neighbors, we fare well. As far as general dental health, when you compare Oklahoma to our neighboring states, the demographics of it tend to be states that are south of us, unfortunately, for whatever reason, have a little less dental health than we do. States north of us have better dental health than we do. States of Missouri, Kansas, Colorado, New Mexico all have better statistics as far as dental health is concerned compared to Oklahoma. States of Texas, Arkansas, Louisiana, their statistics are a little bit lower. As far as nationally, that's not something that unfortunately we can be very proud of. We're actually quite a bit below the Americans' standard as far as the national standard as far as dental health is concerned. One of the huge areas that we seem to be really lacking in is the number of patients that don't have any teeth at all, Ken. We find that Oklahomans have the highest, statistically, number of patients that are completely toothless in one jaw or the other. And we're higher than anyone else in the country in that statistic. We're also higher in the number of, they do a lot of studies with school-age children. Third graders is what the normal common grade is for them to do those type of studies. We're higher than anyone in the country as far as the number of children that have at least one cavity in their mouth, be it filled or not filled. And we're also highest in the country of the number of children that have teeth that are not restored. So regionally, we're not that bad, but as from a national standpoint, we have quite a few problems.
What changes have you personally witnessed in the last 20 years? I know you got into some of them, but it seems to me like we've come a long way very quickly.
Oh, it's been a remarkable 20 years. Prior to my beginning in dentistry in the early 80s, the biggest change that dentistry saw was the advent of the high-speed handpiece. For patients to understand that, it's that really bad thing that none of us like. It's the dental drill. Okay. And years before, in the 50s and even early 60s, a lot of dentistry was done with belt-driven handpieces, things that as younger children we can all remember seeing this big belt and apparatus, all kind of things all over the place. The advent of the high-speed handpiece allowed dentists to clean out a cavity much quicker and easier for the patient, and really a lot easier for the dentist. Unfortunately, that also had an advent of being a lot easier to cut down healthy teeth much faster. The advent of carbide steel burrs and diamond instruments, drill bits, if you will, made it very easy to just take and cut down a tooth quickly for a full coverage type of crown, be it a gold crown or a porcelain crown or whatever the case may be. And there was a lot of unnecessary tooth structure lost in those type of procedures. Other changes I've seen, we don't fill hardly any teeth the same way that we filled them 20 years ago. When I was in dental school, the only filling technique that we had, and we'll see some of these later, was Amalgam Restorations, silver fillings that we placed in people's teeth. Good functional restorations, but they had some inherent problems in function that as people would chew and heat and metal expansion and contraction, they would crack. They would crack teeth, cause problems, recurrent decay underneath those silver amalgams. The other advent is broken down teeth that needed to have full coverage crowns. We did full coverage crowns. We cut down the entire tooth no matter what. And today we just conserve a lot more tooth structure, Mr. Mayor. We don't have to cut down a healthy tooth completely to a nub to restore it. And that's really exciting today because that gets back to what the good Lord put us on this earth to do, was to repair the damage that was done, not create more damage. So now we can conserve a lot more tooth structure. We can actually implant teeth in people's mouths. And it's just a much more conservative profession than it was 20 years ago.
Let me jump in here and get us to a break. We're visiting with Dr. Paul Shadid. We're discussing dental care and all of the many different types of procedures that can bring back teeth to their what they're supposed to look like.
Their original health and strength.
We'll be right back.
Very good.
Welcome back to The Verdict. Mick Cornett, Kent Myers with Dr. Paul Shadid. We're discussing dental care. I'd like to see some pictures now and some examples of what you can do now that you couldn't have done even a decade or two ago.
Well, as we had discussed, Mr. Mayor, bonded dentistry, where we can actually chemically adhere restorations to teeth, has revolutionized the way we do general restorative dentistry.
Okay, so this is the way it used to be done.
That's the things that used to be done. You can see the large silver amalgam in the tooth, and you can see the areas of degradation and fracture lines at the top of that one center piece. And that's what typically happens with silver amalgams over a period of time. The metal will expand, contract, and you open these gaps or micro leakage around the sides. Today we can go in and we remove the existing amalgam restoration that's in the tooth. In the past, we used to have to take an impression of that and temporize it with some type of a temporary material and have the patient come back for the final delivery of the restoration. Today, we're using a product called Cerac, which is a single appointment crown that can be done.
By single appointment, one visit to the dentist.
One visit to the
Wow.
dentist, one time to be anesthetized, one time in and one time out.
And the bottom pictures we saw was what it looked like when you'd finish, or when
After the
dentist had
restorations were
changed,
completed.
yeah.
That's exactly right, after the restorations were completed.
Let's look at one other picture that I'll...
These are very common type of things that we do on a daily basis in general practice. You can see a large silver amalgam, a large gray area at the top left-hand segment of that tooth in the before part of the picture. And that graying segment is where the tooth has actually cracked and there's recurrent decay underneath there. In the past, we would clean out that part of the old filling and the part of decayed tooth structure that was there. We'd do some type of reconstructive buildup on the tooth, and then the remaining 3/4 of that healthy tooth would be cut down for a full coverage porcelain crown in order to restore it. You could do some gold restorations in situations like that, but patients don't want to have gold teeth anymore. Gold restorations are still fine restorations, still indicated in some situations with extremely strong bites, patients that have a tremendously amount of power. But for the most part, if you wanted to try and be conservative, you were very difficult to do that, so you had to cut down more healthy tooth structure so you could put porcelain on top of the tooth, and we don't have to cut away as much healthy tooth structure today.
Well, I know that there are some of our viewers who are patients that have to have braces.
Yes, sir.
And I think on this top picture that we're looking at, we can see the white down near the bottom of the tooth on the top picture. I guess that's due to braces?
Braces and mouth breathing and demineralization of early breakdown, if you will, of tooth structure. Those are tooth scars on teeth. They could have been caused from any other number of reasons. Baby teeth that were traumatized, and as the baby teeth sat there, it caused a little scar to develop around the top of the tooth.
And how would one change that to the shot we saw on the bottom?
What we have are porcelain veneers now that we can very easily do a laminate cover over the top of the tooth. Laminates, just like any laminate that most of your viewers are familiar with. A Formica is the most known laminate in the world. It's very thin and yet it's very strong. Porcelain is the same way. We can make porcelain laminates less than 1 millimeter thick. You have to cut away very little healthy tooth structure in order to get to that final result of being able to.
Before we look at another picture, you've said 2 or 3 times, and I want to ask you to go back to it, about it seems to be important that you cut away as little tooth structure as possible.
Absolutely.
Rather than just taking the tooth out or just cutting it down to the nub. You've got a model there that I'll be glad to hold up if you'll
well,
hand it to me. And
as we had discussed earlier, the absolute degradation, the absolute demise, or the beginning of really difficult times for patients are when they become toothless, especially in the lower jaw.
And the top shows full teeth.
Full set of teeth.
And then going down, it shows degradation.
Early loss of the teeth, up to a 70 or 80-year-old patient that absolutely has what we call a pencil-thin jaw. Those things are very difficult to restore. It's difficult to make an artificial set of teeth that fit comfortably for patients on something like that. In a situation like that, you have something that's actually pathologic. The smallest fall, and elderly patients fall, that's a fact of life. When they fall, if they hit their jaw just right, they're going to have a fracture of that mandible, a fracture of their lower jaw, and then their problems can really begin.
Well, explain to me why losing teeth affects the jaw.
Well, teeth and jaw bones are just like any other bone in our body. They need exercise and stimulation to stay healthy. Teeth inside the jawbone stimulate the jaw to actually retain the bone. Patients that actually grind their teeth sometimes can actually grow more bone around the teeth because they have stimulated the bone so much it's laying down more bone. That can even be another problem that we have. That's a very serious problem for someone that ends up needing artificial teeth. But as those teeth are removed, that bone is going to resorb. It's going to wear itself away because the alveolar bone, or the bone that actually holds the teeth in the jaw, has no reason to be there anymore. You set an artificial set of teeth on top of that. It's a piece of plastic sitting on top of soft tissue. There's no stimulation to that at all. It actually works negatively on the bone, and eventually, if they've lost their teeth for long enough, they'll end up with a situation where they have very little jawbone left. That's where many of these implant type of restorations can help elderly patients, patients that have lost all their teeth, be able to function again, be able to use a lower denture that doesn't just move around all the time, be able to fabricate something that can actually snap into a patient's mouth. We can place 2 implants inside a jawbone, be able to create an artificial set of teeth that can actually snap onto the patient's implants, and as that is done, it allows them to function much more readily. As this model can be seen, there's an implant placed in the bone, which would be placed in any artificial jaw as well. And once that is done, these small posts are placed on top of it, and we can make a denture that, as you can hear, snaps into place.
And that's actually the way it works.
And that's the way it works. And it sometimes takes me much more than 2 fingers to be able to remove these things after they snap into the patient's mouth.
And that's important. That stability is important.
Absolutely, because this does not now move side to side, and you can't, I mean...
You can eat corn on the cob or apples or
I love that
whatever.
when they show those things, and there are so many dental companies that show artificial adhesives that you can eat an apple. Well, made well, you can eat an apple. I'm not going to say that every patient can conquer that, but it sure does give them a one-up on being able to function and have a more normal life as far as being able to go out to dinner and be able to chew their food properly. As Kent, you and I discussed one time, the beginning of the digestive system is how well you can chew your food. Can you digest your food well enough? Can you masticate it, chew it good enough to get it into your system, or are you going to live on a liquid diet for the rest of your life? It's very important, especially for elderly patients.
Paul, in the few minute or so we have remaining, you've practiced 20 years and you've been on the cutting edge of a lot of changes, and things are dramatically different today than they were when you started. Just put on your prophet hat and tell us how things are going to change in the next 15 or 20 years in dentistry.
Well, if we have as many changes in the next 20 years as we've had this 20, it's going to be just unheard of, the amount of advances that we make. But medical science is that way. It is almost true that the longer you can wait to do something, something better is going to come down the road, and dentistry is no different. I look for adhesives, the type of bonding materials that we use to chemically adhere restorations and fillings to teeth. That's going to continue to improve. It has improved immensely. Every year something new comes out that makes it easier for us and more dependable and stable as far as being able to bond things to teeth. Self-curing adhesives will be commonplace. Being able to place tooth-colored fillings in teeth without all the bonding agents and things on these lines, just being able to put something tooth-colored in the tooth will be revolutionary.
Before we finish this up, just in a sentence, what's the advice you give to any patient about how often they ought to be in touch with you or their dentist? How often should they see the dentist?
Prevention is the absolute key.
And how often?
We can, at least every 6 months.
Okay.
We can take care of most everything very conservatively if it's caught early. Decay can be detected much earlier today. Fillings can be done with air abrasion or lasers that don't even have to cut the tooth. You don't even have to be anesthetized to restore the tooth, but it can't be done if it gets really large.
Okay.
We appreciate you being on The Verdict.
Thank you
Paul.
for having me.
Appreciate it.
Kent and I'll be back with the final word after this. Welcome back to The Verdict. Mick Cornett with Kent Myers. Today we learned a little bit more about dentistry, cosmetic dentistry, and really all phases.
Yes, but we didn't get everything done. Dr. Shadid is very kind to come and share his time with us, but we want to bring him back in 2 or 3 months to talk about complete makeovers, restorations, to talk about lack of dentists, and the way the dentistry profession is changing and the makeup of it. And so he has agreed kindly to come back and visit with us again. And we'll have another show that won't duplicate what we've just done, but we'll kind of finish out the story on dentistry. But let's have a little quick quiz. When you go into the voting booth on November 2nd and vote for the president, are you voting for President Bush or John Kerry? I'm not asking which.
Right.
When you cast your ballot.
Right. Now, I know the answer to that. You're actually voting for an electorate to go do the work for you.
You're voting for an elector. And our next show is going to be with Dr. Gary Copeland, who's head of the Carl Albert Center at the University of Oklahoma. We're going to be talking about the Electoral College, why we have it, what it does, and should we keep it?
Yeah, is it necessary? It's a good questions. We'll have that on the next edition of The Verdict. We'll see you then.